what do I do every day?
Yeah, I guess
I,
maybe just walk us through like your typical inpatient day, like when you have, like surgical cases, like when do you
okay.
round,
All right.
stuff like that. Like what time do you get
So,
there?
so I start early. I don't live in Akron. I live a bit away. So I get there a bit before 7, like usually about 6:45. And typically I have a case to do. Most days I have cases.
Mhm.
If it's not my office day, I have one day a week, which is an office day. I go and we meet the patients in the pre-op area. We do what's called a huddle, which is a safety um, protocol. So we meet the patient, the anesthesia team, assisting team, the um, perfusion team. They're all there. They meet the patient, and we go through the play of the day. We make sure that all the essentials, all the quality indicators are met, to make sure that they've had their aspirin, their beta blocker, the blood's available, that the devices are available. We know exactly what we're doing, that everyone's questions are answered. It's an opportunity for anyone to speak up and say, what about this? Or we forgot this. So when we go back to the room, there's no question about what's going to happen. We do the huddle, and then the patient gets taken to the operating room, and at that time, anesthesia gets their various intravenous lines and monitoring lines going. They don't need me around for that. So at that point, I will either go to a meeting like the heart team meeting, which is from around 7:15 to about 8:15. Usually by then the patient's ready for me, or make my quick rounds through the unit with our nurse practitioners and PAs to make sure everyone is moving forward. Look at the previous day's cases and that sort of thing. So then I get started on the case. And again, it's a team effort. I do the sternotomy and cannulation for cardiopulmonary bypass and harvesting of internal mammary arteries, et cetera. And the really talented physician assisting team gets going on harvesting either vein graft or radial artery graft or both. And I like that. I mean, I have these are advanced practice people who are practicing at the top of their license independently. They do things I cannot do. I can't harvest endoscopically. I don't know how to do that. So I have to have them do it.
Yeah.
And you have to have the right people for it, and you have to attract the right people and keep them on the team and keep them happy. And we try to do that by, as I said, by giving them a lot of leeway and responsibility.
Sure.
So those cases typically, they're long cases. They're not, heart surgery is not quick. It's several hours, depending on things go. So we get going and we get on pump and we do our work, and then we come off pump and close up. And again, I work very closely with anesthesia in this in terms of making sure that we do that everything is looking good. We do intraoperative echo on everybody, make sure the heart functions good, and we check the grafts, make sure those are flowing, make sure the valves we put in are working. We make sure that there's no surgical bleeding, make sure they're ventilating okay, etc. And go through again, checklist. I sign out, our team, and then they go to the intensive care unit, and there we do another checklist again at the bedside to make sure that the team receiving the patient knows what's going on.
Sure.
That's a big game changer too. I can tell you, when I first started in practice, we'd drop the patient off in the ICU and we take off and go do the next thing. And you get calls all night and there'd be questions about what's going on. But we do a formal sign out where the nursing staff receiving the patient knows exactly what's going on, and what's going on. And most of those patients, when I started in practice, patients that had heart surgery were usually intubated all night. They were kept sedated.
Oh, really?
Oh, yeah.
That's
That was crazy. Yeah, they were intubated all night. And the next day you come in, tell them, okay, go ahead and wean. Today, I mean, we have protocol driven. They're extubated in just a couple of hours, and they're very quickly. And this is really beneficial. This has changed a lot for patients.
Wow.
So yeah, we move quickly. They're extubated quickly. The next day, most the lines come out, and with the day the chest tubes come out, and go out of bed into a chair by the next morning, and they're walking the next day, up and moving, and hopefully home within about 5 days. That's the goal.
That's pretty amazing. I mean, for operating on such a critical organ and somewhat invasive procedure to have someone back where they came from in 5 days is pretty amazing.
Yeah, it's not. It amazes me too. But I think that what's impressive about it is just it's a whole team of people working together, and you have all these protocols in place, and you just have to make sure they're all being paid attention to. I often look at it like you're flying a plane, and I think Atul Gawande, some of the checklist manifesto came from the fact that, there are millions and millions of passengers flying every year without any deaths.
Mm-hmm.
That wasn't always the case because they've introduced checklists into the airline industry. They're very careful, and we've emulated that. And but I look at this the same way. Like when I look at a patient and trying to assess risk, I want to make sure before we take off that everything's working and everything, we know where we're going, and we got enough fuel, and we have everything we need. So I look at that as like the last check before you run down the runway, and then same thing when you're landing. You got to have everything ready to go, and what you're doing. And it results in amazing things. I mean, people come in who are very ill and who are looking at the prospect of heart failure or death, and it's very gratifying to take them through that path and get them to the other side. And I find I would say that, if I was to say what's my biggest satisfaction doing this, I think that's it. I mean, to have a patient, to take someone successfully through that and see them recover and doing very well, and that's very, very gratifying, because there are some really sick people that we help to get back to normal life and relieve their suffering. And then the other thing, as I mentioned, the team aspect of this is it's one thing that drove me to cardiac surgery was working as part of a team, doing something critical. It's not minor stuff. I do find the life and death aspect of it, although it can be very tense sometimes, and it has its emotional toll at times. I think that's something that I find very important to me. And there's also a technical aspect. I mean, I like doing the technical part of cardiac surgery. I mean, I like it's very fine work, and it's very technically dependent. You have to do a technically competent job, and your outcome is very dependent on your technical competency.
Sure.
So that's a challenging thing too, and it for people that are considering that career, you have to think about that. It takes time to develop that technical competency.
Sure, that's why the training
doesn't just yeah, right. It doesn't come overnight, and you have to. It takes time to do it. It's like anything else, you can't. And no one is an automatic at it. No one, you got to develop it over time.
Sure.
And you're always learning. I mean, this. You're always learning.
Right.
Nothing stays the same. And you come out of your fellowship and you think you know everything, think you've seen everything. It's like no. Like within a day, you're like, I've never seen that before. What do I do now? Well, I don't know. I don't know what to do. It happens to me still. Like I've been doing this for 25 years, and I still have things I've never seen, don't quite know how to handle. But that makes it interesting. It's if we did the same thing every day, it'd be very dull. That's one thing that we find funny. Heart teams find funny because there are other surgical specialty teams are like, why do you want to do that? It's like the same operation all the time. Like just do a bypass. Like no, every single one is totally unique. I think you remember that too. Like
oh yeah.
Yeah, everything is a unique situation, and so to say that it's this, that's repetitive, I think is really just don't understand what we do.
No. I mean, people's anatomy are different. People's comorbidities are different. Everything. Yeah.
The strategies, the revascularization strategy is different. It's always a unique situation.